and welcome to another video. My name is Lily, and today I will be discussing bipolar 1 and 2 disorders. We're going to take a deep dive into the diagnostic criteria, clinical presentation, and treatment approaches for these complex mood disorders. So let's get started. I have my notes here and ready to go. So here's just a quick outline for our presentation today. We will begin with a quick introduction of bipolar disorders, then explore more about the diagnostic criteria for both 1 and 2, and the clinical features. From there, we'll discuss the evaluation process, treatment strategies, and highlight changes that have been made in the most recent DSM-5 criterias. And then we will wrap everything up with a very quick case example as well to see how everything ties together. And this is my cat, who will be coming in and out of frame because she is very needy. Go away. So, quick introduction to bipolar disorders. They are characterized by mood swings that include episodes of mania or hypomania and depression. So bipolar 1 involves 4 manic episodes, while bipolar 2 is marked by hypomania and depression. These disorders affect over 2% of, or not over 2%, approximately 1% of the population, and are associated with significant morbidity and mortality. So what are the diagnostic criteria for bipolar 1 disorder? The hallmark of bipolar 1 disorder is a manic episode lasting at least 1 week, and causing a significant impairment or requiring hospitalization. Symptoms include heightened self-esteem, reduced need for sleep, and impulsive behaviors. Diagnosis requires ruling out any type of substance use disorders or medical conditions. Now, in turn, the diagnostic criteria for bipolar 2 disorder involves hypomania, a less severe form of mania, and at least one major depressive episode. Hypomanic episodes last at least 4 days or do not cause significant functional impairment seen in mania. The depressive symptoms must meet criteria for a major depressive disorder, as discussed in a previous videos where symptoms are present for at least 2 weeks or more. Now let's discuss some of the clinical presentations for patients with bipolar disorders. With bipolar 1, patients present with a very clear manic episode, while those with bipolar 2 often experience depressive episodes and milder hypomania. Both forms involve mood instability and a high risk of comorbidities such as anxiety or substance use disorder. So what's the approach to the initial evaluation? As I've said in my previous videos, take a thorough patient history. You want to know the onset, the duration, have they experienced this before, treatment options that they've pursued in the past, what has worked, what hasn't worked. And sometimes it's nice to kind of know, why are they seeking treatment now? Just to get a better understanding of your patient. Make sure that you're building a good rapport so that they are more willing to open up to you and disclose all the information that you might need. As mentioned before, some of the higher comorbidities that patients with bipolar disorders experience could be anxiety and substance use disorder. You want to be able to take that thorough history to know if they do have substance use disorder, what is the substance that they're taking, how often, why are they taking it, have they tried to stop before, are they interested in stopping, to be able to really tailor the treatment plan on something that will work for the patient and something that they can adhere to. when doing the evaluations for a patient in that initial encounter, it's aside from taking a detailed history, you want to kind of include their mood patterns. Are there weeks that they're better? Are there weeks that they're worse? Are there certain events that kind of trigger certain symptoms? You want to be able to assess for that. You also want to assess their energy levels, any behavioral changes that they've been experiencing, and what has helped them that they've been doing at home, and things like that. Are there any triggering factors or anything that they've done that have made symptoms better? Some screening tools that can be used can be mood disorder questionnaires that can aid in diagnosis, and it's critical to rule out secondary causes such as substance use disorder and other medical conditions. Again, you don't want to leave something untreated, treat something completely different, and have patients feel like nothing's working, that they're getting worse, and have the potential of them just not coming back. You don't want to miss anything that can be treatable for those patients. So treatment for bipolar disorders typically involves mood stabilizers, such as lithium or valproate for patients, and is often combined with atypical antipsychotics. Antidepressants should be used very cautiously in patients with bipolar disorders, especially in bipolar 1, due to the risk of inducing a manic episode. Psychotherapy and lifestyle changes are essential parts of the treatment plan as well. If your patient is a child or adolescent, it is important to bring in the family into the conversation for a treatment plan. Educating the family on different parenting styles or coping mechanisms that they can use at home when the child is presenting with certain symptoms. Involving the school is something that could also be an option for children as well, just to keep an eye out for certain symptoms and how to navigate when the patient is experiencing a manic episode, for example. So with the newer DSM-5, there have been specifiers that have been added to the diagnosing criteria to help clinicians tailor a better treatment plan. So there's mixed features between manic, hypomanic, and depressive episodes. There's a greater focus on anxiety as well for patients with bipolar disorder. It just helps create a clearer distinction between when a patient is experiencing a manic episode, hypomanic episode, depressive episode, whether there's anxious distress involved in there, and it overall just helps clinician build a better approach to treatment for that patient. So with this really quick case example, it is a 25-year-old male with mood swings, impulsivity, and periods of extreme energy and decreased sleep. So with the extreme energy and decreased sleep, something that you can think about as far as establishing a diagnosis would be bipolar 1 with mixed features. So what would the initial treatment plan be for a patient who presents and diagnosed with bipolar 1 with mixed features? That would be initiating a trial one of using pharmacotherapy such as lithium. You want to monitor the patient's thyroid and kidney function when you are starting a patient on lithium, just because some of the major side effects that are associated with lithium can have a significant toll on patients' thyroid and kidney function, which is why before initiating any medication, you want to get routine labs, make sure that their thyroid and kidneys are functioning normally before prescribing, and you want to be able to have follow-up visits with that patient to continuously monitor thyroid and kidney functions. Because if thyroid and kidneys aren't functioning well, then lithium may be off the table, and another different type of pharmacotherapy may need to be explored for this patient. Or if they're already on it, sometimes it is enough to warrant the need to switch the medication and try something new. Aside from pharmacotherapy, again, cognitive behavioral therapy is an option for patients, and recommended, just so patients can have a better understanding of their diagnosis. They are able to talk more about what the symptoms are doing to them mentally, physically, emotionally, spiritually, and just being able to really tailor that treatment option for them. So to conclude, bipolar 1 involves more manic episodes, whereas bipolar 2 involves more hypomania and depressive episodes. The newer updates to the DSM-5 kind of provides better clarity to the diagnosis, and in order to have very effective management of this disorder, it requires a very multidisciplinary approach, from lifestyle changes that the patient initiates for themselves, cognitive behavioral therapy, pharmacotherapy, and even having the support of the family system, if that is able to, can truly improve patients' overall quality of life. And here's a quick list of references I used to put together the information that I used in this presentation today. I hope that you were able to learn a little something from my presentation, and that it made the learning experience just a little bit more enjoyable.